आज मैं जो मेरा मूड क्या ना ही होते सीएनजी कार लाओगे नहीं रिक्शा लाओगे क्या हुआ मेरे ख्याल गाड़ियां तो ये जो कहनी वो पूछ दे इनके किस पे है। हाँ जी अस्सलाम वालेकुम। हाँ चलो जी ठीक है कल चल ठीक है क्लास है मेरी ओके। हाँ जी यहाँ पे अंदर बैठ के ना तो बाहर देखो बारिश हो रही है तो ऐसे लगता है कि ठंडा मौसम है। बाहर जाओ तो अक्सर बड़ी अजीब सी। जी अस्सलाम वालेकुम क्लास हाउ आर यू सादिया सिदरा जमील एंड असमा खान। बारिश हो रही है बड़ी अजीब व कसीम गरीब किस्म की। हाँ जी आप लोग मुझे सुन रहे हो आवाज़ मेरी क्लियर आ रही है बिल्कुल। अच्छा ग्रुप में कौन कौन से हमारे हैं लोग मैं एक ना लिस्ट मेरे ख्याल में मैंने शेयर कर दी होगी आपको। यस। अच्छा सादिया, मैंने ना ग्रुप में एक आपको चेक लिस्ट एक शेयर की है, काइंडली उसको देखें। अब यहाँ पे चेक लिस्ट तो मेरे ख्याल में नहीं हो सकती शेयर, कोशिश करूँ क्या पता हो जाए। ये तो प्रेजेंटेशन फॉर्मेट होगा, तो कोशिश करते हैं, अगर हो जाता है तो हम उससे डिस्कस चेक लिस्ट को न्यूरोलॉजिकल सिस्टम की कर लेते हैं। नहीं यहाँ पे नहीं होगी, यहाँ पे सिर्फ जो है ना वो पीडीएफ को ही शो कर रहा है, पीपीटी को। गुड इवनिंग सर अरूज, आप लोग देख रहे हो अपने ग्रुप में मैंने जो शेयर किया है? इसको असाइनमेंट बना समझ के करें, और जब आप लोग वापस आएंगे तो ऑब्वियसली मैंने आपके पोर्टफोलियोज और आपसे ये काम करवाने हैं कि आप जो सिस्टम पढ़ते हो उसके अगेंस्ट चेकलिस्ट के अकॉर्डिंगली आप पेशेंट को असेस करते हो, जो कुछ पढ़ा होता है उसको आप इम्प्लीमेंट करते हो क्लिनिकल एरिया में। ठीक है, अपना कोई भी एक पेशेंट आप ले सकते हो ड्यूटी पे, 15-20 मिनट का काम होता है। ठीक है, सिस्टम तो आप 4-5 दिनों में एक पढ़ते हो, लेकिन उसको परफॉर्म जो है ना 20-1 मिनट में हो जाता है। उसकी फाइंडिंग्स एंड जो डॉक्यूमेंटेशन होती है वो फाइनल करके उसको पोर्टफोलियो पे लगाएं कि आपने क्या कुछ पढ़ा है, फिर हम उससे रिलेटेड जो है ना एग्जाम्स ले लिया करेंगे। अभी आप सबके लिए है कि ज़रा इसको चेकलिस्ट को डिस्कस करें आपस में, ठीक है। और न्यू टॉपिक इंशाल्लाह, या कोई और वीडियो देखने की ज़रूरत है इस टॉपिक को स्ट्रेंथन करने के लिए, आपसे ये समझते हैं कि हमारी अंडरस्टैंडिंग थोड़ी सी बाकी है रहती है, इसको मज़ीद वगैरह वो करने हैं तो वो भी बता दो मुझे। हेलो जी, वालेकुम सलाम जी। चार्जर जी मैं एक मिनट सर, रिफ्लेक्सेस की वीडियो, रिफ्लेक्सेस की वीडियो देखनी है, ओके एक मिनट। हाँ 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 ये तो मैं मामा को भेज दूंगी, अपने बाप का जैसे हम कंटिन्यू। ठीक है जी, ठीक जी, ठीक ओके। यू आर वेलकम, यू वेलकम। अच्छा जी, मैं वीडियो से एक मिनट आपको दिखाता हूँ। अस्सलाम वालेकुम सर। गुलाम रसूल। अच्छा मैं करता हूँ सर। अच्छा सादिया, रिफ्लेक्सेस की वीडियो आपको चाहिए है, मैं अभी शेयर कर देता हूँ, जस्ट वेट अ मिनट।
Catch the tip of his little finger with his thumb while you resist him. Hip abduction. Hip head. Prominent hand, mainly better forward. This video presents examination of the nervous system, which includes assessment of body position, involuntary movements, muscle bulk, muscle tone, strength, and blood pressure.
Neurological examination.
Right, so is it swab? Okay, good. Fantastic.
Come on in.
Washing my hands. Hi, Mr. Hoffman. I'm Nancy. I'm a nurse from Harper College. How are you?
Doing very well, thank you.
Good. I'm here today to do a neurological assessment.
Okay.
And I'm going to start out the assessment by asking you 2 questions.
Yes.
Have you ever had a stroke?
No.
Okay, good. And do you have any other problems with your coordination or with your brain that you're aware of?
No.
Ever have meningitis or MS?
No.
All right, good. Okay, that's good to know. So as we do this, I'm going to start by checking all of your cranial nerves, and then we're going to check your coordination, and then we're going to check sensation, and then at the end we're going to do some deep tendon reflexes.
Okay.
So we'll start out by just talking with you, and we're doing what's called a mental status assessment.
Okay.
So I'm first off noticing your behavior, you're awake and alert, and cooperative and responding well. And then I'm also noticing your cognition. So I'm going to ask you some kind of silly questions.
Okay.
So can you tell me what month it is?
This is the month of August.
Okay, that's correct. And can you tell me who your favorite president is?
He's dead, but it was President Ronald Reagan.
Now I happen to know the answer to this question, so I know that's correct. But who's the current president?
Ooh, that's a tough one. Obama.
Obama is the current president, exactly. And can you tell me who I am?
Yes, Nancy Aberraker.
Okay, good. So he is oriented to person, place, and time. And tell me why you're here today.
Well, I'm here today to be checked out, and we're doing videos for the assessment courses at Harvard.
Okay, so and he's also aware of the situation. So he's oriented times 4, person, place, time, and situation. And I am also noticing that his dress is appropriate, his affect is appropriate, his facial expression is all appropriate for the situation. I also need to screen him for depression and suicidal thoughts. This is a screening that's done at every healthcare encounter today. It's required by the state of Illinois because suicide is causes a high rate of death here in our state. So, sir, have you ever been so blue that you felt like hurting yourself?
No.
Have you felt depressed or unhappy lately over the past 2 weeks? Like
No.
normal activities are not fun?
No, I've been having fun.
Okay. All right. So at that point, I can stop my assessment. If he answered yes to any of those questions, then I would probe further with more questions about that. So, but he answered no for the first screening, and then we're done with that. All right, so we're going to move on for the cranial nerves, and we're going to start with cranial nerve number 2, and that is to your visual acuity. So we checked your visual acuity today, and we would check it for this assessment as well, using the Snell and our eye chart. Standing 20 feet away, we would check both your right and your left eye, and your vision was 20/25 in both eyes. And continuing on with cranial nerve number 2, we would do a confrontation test. Can you stand up? And using this card, can you place this over your left eye? And then I will place this over my eye, and tell me when you see my fingers.
I see them. Yes. Yes. Yes.
Okay, and then switch. Look straight at me and tell me when you see my fingers.
Yes. 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 Yes.
Okay, good. Your peripheral vision is intact. That's cranial nerve number 2. Have a seat. Now we're going to check cranial nerves number 3, 4, and 6. Can you take your glasses off? You can just hold on to me for a second. And I want you to follow this pen in the 6 cardinal positions of gaze, keeping your head straight. And I see conjugate movement of both eyes together in the 6 cardinal positions of gaze. All right, and just follow this. I'm going to bring it in towards your nose. Good, and I see good accommodation. And then I'm going to look in your pupils. I'm going to shine the light in. And I see that the pupils, both of them, respond to light by districting. And I would document that as PERLA. Pupils are equal, round, reactive to light, and accommodation. That is cranial nerves number 3, 4, and 6. And then moving on to cranial nerve number 5. Cranial nerve number 5 is facial, where we are going to look at some movement of your face. So can you smile and frown and show your teeth like and I'm just going to check the muscles here, so grit your teeth. And I can feel those muscles get nice and tight, they're relaxed. And then also there is a sensory portion to this cranial nerve, so can you close your eyes? Tell me when you feel the cotton whiz. Say no.
No. No. No. No.
Wonderful. All right, you can open your eyes again. Moving on to cranial nerve numbers 6 we already did, so we're going to move on to cranial nerve number 7. And can you lift your eyebrows up and down, and then smile and frown. And squint your eyes closed real tight, and then open them. All right, I'm looking for symmetry of the face. And remember, with this cranial nerve damage is the Bell's palsy, where you would see drooping of one side of the face, or you might see that with a stroke. So that's cranial nerve number 7. Cranial nerve number 8 is the acoustic. I'm going to whisper something in your ear. I want you to repeat it.
Green wall. The Cubs are going to win.
All right, so his acoustic nerve is intact. You can put your glasses back on. So that was cranial nerve number 8. And then moving on for cranial nerve number 9 and 10. Can you open your mouth really wide and say, ah? Wonderful. And I see his uvula goes up and the soft palate goes up, and that indicates that cranial nerve number 9 and 10 is intact. And then cranial nerve number 11, can you turn against my hand? And turn against my hand. And shrug up against my hand. Good, and that is cranial nerve number 11 is intact. And then cranial nerve number 12, can you stick your tongue out? And the tongue should be in the midline, which it is. So now we're going to check muscle strength. So we'll start with the upper extremities. Can you please hold your hands out like this? And we would do that for a count of 10. And then can you squeeze my fingers? Squeeze as hard as you can. Squeeze really hard. Hard as you can. You're not going to hurt me. All right, good. Okay. So the reason that we check strength in this manner for a neurological assessment is that this arm lift is part of the NIH stroke scale that's used across the nation for our assessment of stroke. And doing the finger squeeze is an easy way to check assessment of strength of the upper extremities. If you give 2 fingers, the person can squeeze as hard as they want, they're not going to hurt you. If you give your whole hand or you give 3 fingers, you may come back with your fingers like that, which is usually not very pleasant. And then for the lower extremities, I'll have you lay back for a minute. This is an easy test to do. You probably want to lay back. And I want you to lift this leg up off the bed. And we do that for a count of 5. 1, 2, 3, 4, 5. Good. And then lift this one up again to a count of 5. 1, 2, 3, 4, 5. And relax. Again, that is part of the NIH stroke scale. That's why we use that method. And then if you could press down against my hands and pull up against my hands, that also tests strength of the lower extremities. Okay, so from there, we're going to do some tests of your coordination. So can you do this a finger? Touch each finger as quickly as you can. And then do it with the other hand. All right, good. And now touch your nose, and then touch my finger. Go as quickly as you can. All right, that's good. One caution while you're doing this is that when your client has their finger to the nose, okay, at that time you can move it, but don't, as they start for your finger, don't move it right at that time. All right, that's not a fair test then. So you can move it while the finger's there, but then hold still as soon as they start coming towards your finger. So we're going to check coordination of the lower extremities too. So can you take your shin and your heel, just run it down your shin. And then do it on this other side. Just run it right straight down. All right. And then can you stand up for a moment? We're going to do the Romberg's test. Put your feet together and put your hands at your, stand up straight. Put your hands at your side. Put your hands at your side and close your eyes. And we would count to 20 seconds, and he should be able to maintain this standing straight and still without falling over. Make sure you're here just in case a person does start to lose balance so they don't get hurt. So 1, 10, 11, 20. Very good. You can open your eyes. And then can you walk a couple steps towards that outlet there? Just like about 3 or 4 steps, just normal. And then come back and walk heel to toe. Heel to toe, like this. You can relax your arms. There you go. Okay, good. Fantastic. So your coordination is intact. And then we're going to check the sensory system. So the first thing that we're going to do is check your sharp-dull discrimination. So you start this by having your eyes open and explaining this is sharp and this is dull. You can use a paper clip that you've opened up. You can also use a cotton swab to do this, whatever you're comfortable with. So close your eyes, and then you're going to tell me whether you feel sharp or dull. I'm going to do this all over.
Dull. Sharp. Dull. Sharp. 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 That was dull. Sharp.
Do not draw blood when you're doing this.
Sharp. 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 Dull. 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 Sharp. Dull.
All right, you can open your eyes. And then, again, we're going to check your light sensation. I'm just going to use a cotton ball, and I just want you to say now when you feel that. So close your eyes and say now when you feel the cotton ball.
Now. 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 Now.
All right, good. And then last thing, eyes closed, and hold out your hand, and tell me what's in your hand. You can feel it with your hand. Tell me what's in your hand.
It's a coin.
Okay, good. You can open your eyes then. All right, so that's all for our testing of sensation. Now we're going to move on to the deep tendon reflexes. So I'm going to start this by having you just relax your arm up here. All right, I want you to be really, really relaxed for this to work. And you can talk to Amy over there.
Hi, Amy.
While you're
Hello.
doing this. I have, the way I'm going to do this is have him flex a little bit so I can find that tendon and then have him relax. You really have to be relaxed or this will not work. You also have to hold pressure on the tendon pretty firmly. You can see my thumb is on there pretty firm. Use the pointy part of the reflex hammer and you have to give it a good whack. And I could feel his tendon moving, but what
I
I'm
could too.
looking for is for his fingers to move, which I did not see. There we go, now we saw a little movement there. Okay, and then we would do the same thing on the other side. You put your arm up here. Again, I'm going to have him flex so that I can feel where that tendon is. I'm going to hold it pretty firmly. Now, I have very poor aim to do it with my other hand, but if you can hit your thumb with your left hand, that would be lovely. I'm not too good at that. Okay, so relax your hand. Talk to Amy over there.
Hello, Amy.
Hello.
Hold it firmly. Oops, I didn't do so well with that. And then what I'm looking for, there we go, is for those fingers to move. So that one tends to be a little bit stubborn sometimes. When you're trying to do that, it's important for the person to be relaxed. And then we're going to move on to the patellar reflex. Okay, so you're going to feel where that kneecap is, and then right below there is where you're going to hit, and you want the person to be really relaxed. When you hit, you don't want to hit like this. You want to hit loosely, like that when you hit it bounces off. you should be able to get a nice little kick from doing that, which doesn't seem to be working well with this. Are you relaxed?
Yes.
Are you sure? Oh, well, we got a little one there. Okay. There we go. Okay. And then
Try one more
last,
time.
try it one more time. Yeah, be careful that you don't get kicked in the face. Okay, lay back down for a second. That's okay. I'm gonna get my payback right now. Last thing is the Babinski reflex. So you're going to draw a J up the side of the foot and across the sole of the foot. Normal response for an adult is curling of the toes. So draw up the foot and across. So either no response or curling of the toes is normal. An abnormal response is a fanning out of the toes and flexion of the great toe. That would be an abnormal response. So a negative is normal, just like if you get an x-ray and it's negative, that's normal. So negative is the curling of the toes, okay, like that. A positive Babinski is bad, and that's the fanning and flexing of the toes. Okay, I think that we are done with our neurological assessment.
I'm Victor Sung. I'm a neurologist at UAB, and welcome to the neuro exam. This is Erin. She's going to be helping me in the demonstration today, but I think it's pretty straightforward on how to use the card. The third cranial nerve is the oculomotor nerve, so 3, 4, and 6, or oculomotor, trochlear, and the abducens nerve, which are 3, 4, and 6. Those three nerves move the eyes as their primary functions. So when you assess extraocular eye movements, then you can really quickly assess the pivot point so that you can cock it back and really swing it forward. And with a larger degree of rotation, you can get more force with the reflex. So that's the main thing, is if you have it, use it correctly. I'll even demonstrate, because I know that people do this, is if you don't have a hammer at all, if this is this up or down?
Down.
Is this up or down?
Down.
Is this up or down?
Up.
Okay. So that's normal, obviously, and I don't have to necessarily make the patient close their eyes, because my movements here in the finger and the distalmost part of the finger are so subtle that they may not be able to see it unless they're staring right at it. But you can do that, and certainly you don't need to do that if you're doing it on the feet, because it's so far. Unless they're craning around and trying to look at it, you might try to cover it up or tell them to close their eyes. The importance here is that if you do it, like some people do proprioception, if you just do this. Now, I'm going to move your finger up and down, up, is this up, is this down? One, by doing that, you get stretch cues in the skin. If I lift up like this, you get stretch cues in the skin here, and stretch cues in the skin here as I move it down. That's going to overcome any minor proprioceptive deficit, and a large motion like this is likely to still be intact. So you want to really isolate the distalmost part of the joint. And the same thing with the feet. If you lift and you can also get pressure cues too. If I lift up like this, you can feel pressure from below here, and as I push down like that, you can feel pressure on the top of their finger going down, and all that gives them cues and can kind of negate an abnormal proprioceptive deficit. And the same thing with the toes. If I'm moving the whole great toe up and the whole great toe down, they get a lot of pressure and sensory cues in the skin that will give them a sense of where the problem is. But as you can imagine, that's, as I mentioned earlier, I don't like toes or toe jam, and if you get right on the sides of the great toe and are trying to wiggle it up and down just a little bit, you're getting right there, crevice between the great toe and their second toe. But also, I mean, Erin doesn't have any toe jam, but I'm just demonstrating on the hands for ease here. right, so the next part of the exam is the reflexes. As we talked about at the beginning, there are different hammers that you can use, different sizes, different weights. We'll kind of demonstrate a little bit that the hammers with different weights, it's easier to use. The ones that are heavier, like the Tromner, you can see that just the weight of it makes a weightier sound here. Whereas the Tomahawk here, it's harder to do. The key thing with the Tomahawk, and there's nothing wrong with using it, the key thing is knowing how to use it. So all Tomahawks have, well, they're called that because of the shape of the head of the hammer, but all Tomahawks have this bottom part of the reflex hammer called the spoon. And the key thing is using it correctly. I see this all the time where students use a Tomahawk hammer and they hold it like this. And they're not going to get it, you know, if you do this, you're not going to get any kind of reflex. Whereas what this spoon is designed to be is a fulcrum. So you're supposed to put your thumb and index finger into the spoon and use it as a pivot point so that you can cock it back and really swing it forward, and with a larger degree of rotation you can get more force with the reflex. So that's the main thing, is if you have it, use it correctly. I'll even demonstrate, because I know that people do this, is if you don't have a hammer at all, and you know, of course, no self-respecting neurologist would ever admit to using the side of their stethoscope, but we know that people do that. And you can do that. I mean, this is a nice hard surface, and you can use that to strike to get a reflex, but the key thing is knowing how to do it. If you use your stethoscope to get a reflex, then you don't want to hold it way back here and then swinging all over the place and you have no control over it, right? So if you do that, you need to hold it more down towards the bell and really get a pivot point. And it is heavy enough that it really can elicit a reflex there. But I probably won't demonstrate with that, okay? So those are the main things with the reflexes. All reflexes, the main thing with the hammers, all reflexes are better across a slightly flexed joint. So that's pertinent in the hospital if a patient's laying down and their arms are straight. If their arms are straight and you try to tap here and get a biceps reflex, you're going to get nothing. Same thing if a patient is supine in the bed and the legs are out straight like this and you tap the patellar tendon, there's no place for the leg to move. So I'll demonstrate some things on how do you overcome those things. All reflexes are better across a slightly flexed joint. Most of the reflexes, except for the biceps reflex, you're going to tap the patient right on the tendon. For the biceps reflex, that's the exception. What you should do is, with your non-striking hand, with that thumb, find the head of the biceps tendon, put your thumb right on it, and then you're going to strike your thumb, not the patient. And then if you strike it there, even if the arm doesn't visibly move, you can feel the tendon contracting under your arm. Under your thumb. So that's the proper way to get biceps. Triceps, the easiest way is you can just have them dangle their arm here and you tap right here on the triceps tendon right above the olecranon. And then for patellar tendon, obviously, you want to strike right below the patella on the patellar tendon itself. Try not to strike the patella, especially not repeatedly. That can cause pain to the patient. You want to strike right on the patellar tendon, and you'll get a reflex there. And we'll demonstrate the Achilles reflex as well. There's a way to get it. The simplest way is if reflexes are better across a slightly flexed joint. If you apply a little bit of upward pressure and lift up the foot a little bit, and then you strike right on the Achilles tendon itself, then you'll feel the foot push down into your hand, and that's the reflex being present. Reflexes are graded as well. Reflexes are graded as 2+ being normal, 1+ is decreased or a little bit less than normal, 0 obviously is absent. And then going the other way, 3+ reflexes is increased, and 4+ is pathologically increased with the presence of clonus. Clonus is when you put tension across a joint that it pushes back in a repeated way. So in the hands, if you get clonus at the wrist, you would test it by doing something like this, like testing wrist extension. You go like this, and then clonus at the wrist would be the hand would push back in this repeated way, kind of with these repeated beats. And you can grade out clonus. So if you do that and they have clonus, then it'd be pathologic. You would score 4+ with clonus, and you would also describe the degree of clonus, like a few beats of clonus or sustained clonus or something like that. So reflexes being increased indicates that you have a central lesion of the corticospinal tract most commonly, and then if reflexes are decreased, then there could be something peripheral or somewhere else, but the the central part of the corticospinal tract is not necessarily involved, but it might be somewhere else in the nerve or the muscle that's the problem. So reflexes can roughly tell you whether you're in the central nervous system or the peripheral nervous system, which is why it's an important part of the exam. All right, so to demonstrate reflexes in the upper extremities, just relax your arm. I'm going to tap on your reflexes. Okay, just relax this arm here. Okay, all right, same thing over here. Okay, just relax this arm here. Okay. On the lower extremities, patellar reflex here. If I just use the trommner and just do a light tap here, right? So you get a reflex like that. If I use this tomahawk here, I have to strike pretty hard to get the same kind of reflex. But you know, there are normal reflexes there, so even with the light tap, you can still get it. The key points, whichever hammer that you use, is that the fatter end is for adults and the pointier, smaller end is for children. So that's the normal design of the hammers. The other thing with the Achilles reflex that I think is good to demonstrate, all reflexes, as we said, are better across a flexed joint. And so it's easy on an Achilles reflex if you just tap like this and you can't tell if there's a reflex there or not. But what I usually do is I'll just apply a little bit of gentle pressure on the Achilles by stretching it a little bit, and then I'm holding it with one hand and I tap with the other hand, and you can see it and feel it push down in a delayed way, and clearly that reflex is present. And you can do the same thing with the tomahawk here. So just a little bit of gentle upward pressure on the foot, and that puts a little bit of tension on that Achilles tendon so that when you strike it, you'll get a nice reflex. As we mentioned previously, when the patient's supine in the bed and their limbs are extended, getting reflexes can be more difficult. The easiest way to do that, for the arms at least, for biceps, is just to bring the arm up and rest it on the abdomen here, and then it's slightly flexed across the elbow, and you can place your thumb on the biceps tendon. You just give it a nice strike here, and you can see their arm move visibly on their abdomen, and you get a nice biceps reflex that way. So similarly for the patellar reflex here, if their legs are straight and you tap on the patellar tendon, you can't really see anything. So the simplest way is to turn the leg out just slightly and then bring it up into a slightly flexed position. And then you've got a slightly flexed joint here. I usually will support the leg with my opposite hand, and then you just tap lightly on the patellar tendon and you see a nice patellar reflex there. Okay. So the next part of the neuro exam is the coordination exam. And remember, coordination and gait are the two parts of the exam that very commonly are forced to be omitted in a hospitalized patient. So for coordination of the upper extremities, you primarily do finger to nose. Coordination of the lower extremities, you do heel to shin. You can also do rapid alternating movements. That can be something you can do. The thing I want to point out on finger to nose is that many people will do this kind of touch my finger, touch your nose, and have this moving target and be all over the place. But the reality is, in a cerebellar ataxia patient, they're going to have difficulty hitting a stationary target, and they certainly will have more difficulty with a moving target. So, I don't think you need to move it all over the place and try to really trick them. The one thing that you do need to do for finger to nose is you need to put your hand far enough out that they actually have to extend it and reach the target. If you stay this close to their nose and they're just kind of doing this kind of number back and forth, it's going to be too easy. So they need to actually full extension. What you're looking for in a patient with ataxia on finger to nose is as they approach the target, it's going to be kind of all over the place, and they'll have this side to side weaving, and then as they approach the target, they'll have difficulty actually hitting the target itself. And similarly with heel to shin, If this is the heel and they're sliding it up and down on their tibia, then you want to see it kind of smooth up, smooth down. In a patient with ataxia, it will sway side to side on the front of the shin. It's pretty dramatic if they have it. And really, you can't miss it. So those are the things that you're looking for. So for demonstration of coordination, this is the kind of thing that I say. All right, with your right hand, make a pointer finger. Now reach out and touch the tip of my finger. Now touch the tip of your nose with that finger and back and forth between my finger and your nose. Okay, and now the same thing with the other hand. Okay, and in the legs, for heel to shin, what I would say is with your right heel here, I want you to take this right heel and slide it up and down the front of your left shin, all the way up to the knee and all the way back down, smooth as you can, all the way up and all the way down. One more time. Okay, and same thing with the other heel, all the way up and all the way down. Okay, and that's coordination. And so for the gait part of the exam, the two main parts of the gait exam are the unstressed gait, which is natural walking, the tandem gait, which is the term for heel to toe walking. And the Romberg is an optional test that we do in the gait part of the exam, and I'll walk through that. The importance of the Romberg is actually the part where you have the patient close their eyes and they keep their balance. The three things that we as human beings need to maintain our balance in space are vision, our vestibular system in our inner ears, and our proprioceptive system in our legs. So all of us have done this. When you're standing up and you close your eyes and you start to sway a little bit, that's because you've taken out one of those three main systems that keeps you steady when you're standing still. You need two of those three systems intact in order to maintain your balance. If you have only one of them left, then you will fall. So that's what the key part of the Romberg is really that they close their eyes. You're taking out vision, and it puts the strain on the vestibular system and the proprioceptive system. So in a patient with what we call a positive Romberg, meaning they stand up, they close their eyes, and they start to fall, that means they have a problem either in their vestibular system in their ears or in their proprioceptive system in their legs. So it's a nice way. Hopefully, if you found a vibratory deficit on the sensory part of their exam, a positive Romberg would not be a surprise there. If the sensory part of the exam was completely normal, there was no vibratory deficit on the exam, then with a positive Romberg, then essentially you've uncovered a vestibular deficit in their ears, which is going to mean, for me as a neurologist, referral to ENT. So those are the parts of the gait exam, and we'll demonstrate the parts of the gait exam now. All right, so for the gait part of the exam, Aaron, this time I want you to walk straight down towards the wall, just walk normally. And then turning around and coming back. This time, as you come back, I'd like you to walk heel to toe, one foot right in front of the other, like you're walking on a tightrope. All right, that's good. And now turn around and face the back wall this time. What I'd like you to do is close your eyes and just try to keep your balance. So we reached the end of the neuro exam. Just to recap, the main parts of the neuro exam are the mental status exam, the cranial nerve exam, the motor exam, the sensory exam, reflexes, coordination, and gait. It's a lot of different pieces, but each piece, when you break it down part by part, is pretty manageable. If you piece each of the demonstrations together, you can see that each of the parts of the exam is actually fairly short, so the total exam should still be able to be completed top to bottom in less than 10 minutes. And at this point, you would obviously conclude your exam and thank the patient for coming in. And I want to thank you guys for being a part of the neuro exam here, and thank you to Aaron.